Thank you. Next up, we will invite Dr. Naomi Dempsey to the podium to present on precision medicine in breast cancer.
Hi, everybody. Pleasure to be here with you this morning. My name is Naomi Dempsey. I'm a breast medical oncologist with the Miami Cancer Institute in South Florida. And we're going to be talking today about precision oncology in advanced breast cancer, which, even 5 years ago, us breast oncologists were looking really longingly over at our thoracic oncology partners that had all these cool new drugs to use, and we're kind of stuck with the same old stuff. And so thankfully now we are no longer in that situation. Here are my disclosures. So we're going to be talking about targeted therapy options in breast cancer, as well as a couple points on using circulating tumor DNA in breast cancer. So let's start off by talking about the hormone receptor positive, HER2 negative advanced breast cancer space, which is where a lot of our newest and most exciting advances have happened. So it is undisputed that the standard of care first line in advanced hormone receptor positive, HER2 negative breast cancer are CDK4/6 inhibitors. And so once someone progresses on CDK4/6, we really have to think about what are the mechanisms of resistance that led to that progression, because I think that's really going to help us with choosing a second line option, where right now we really have a lot of different second line options, and we don't really have a clear algorithm for exactly what should come second. So when we start to think about resistance to endocrine therapy, one way to think about that is that estrogen receptor signaling independent of the estrogen signal, like Dr. Schwartzberg talked to us about this morning, with mutations in the estrogen receptor that's then just constitutively signaling rather than relying on the signal from estrogen. And so you've heard some of these things as well this morning, that ESR1 mutations are basically not seen in primary breast cancer. They're only seen after you've had the pressure of endocrine therapy. But when you look here in some of these different second line and beyond trials in this space, that ESR1 mutations are somewhere between generally 30 to 40% of breast cancers that have previously been treated with endocrine therapy. And as we all know, we now have an approval for elacestrant for advanced hormone receptor positive, HER2 negative breast cancer with an ESR1 mutation, which is exciting since this is a single agent oral option. A lot of these patients at this point, they're already used to being on something oral and not having to be quite so tied to the infusion center. Really, at least my experience thus far, I've had one patient now on elacestrant and it's really well tolerated. So this is an exciting option for us. You've already seen some of this as well this morning, so I just want to point out a couple of additional points here about the EMERALD trial. This was not a particularly heavily pretreated population. When you look in the inclusion criteria, patients had to have progressed on either 1 or 2 lines of endocrine therapy for advanced disease and could have had 0 or 1 prior lines of chemotherapy. So, whenever we have a new approval, you're thinking about it in these patients where, we're on 10th line therapy, and now I'm excited because they have an ESR1 mutation. Maybe I have a new option. But really, I would say that patient is not really the type of patient that would have been in this trial. And I wouldn't think necessarily that type of patient, even with an ESR1 mutation, would necessarily derive benefit. So really, we're kind of looking more at elacestrant in that second and third line setting. And I think it was really smart that the investigators used PFS in the ESR1 mutant population as their primary endpoint rather than in the intent to treat population, which included those without an ESR1 mutation. You'll notice here that 70% of the patients on this trial had visceral metastasis, so certainly that does not disqualify patients from receiving elacestrant. And as you already saw here, there was a benefit for progression-free survival, specifically in the ESR1 mutant population. And I would just like to point out here the drop-off in the beginning, in the early part of that curve, which occurred in both the fulvestrant and the elacestrant groups, the standard of care endocrine therapy and elacestrant groups. That drop-off are patients that are already endocrine refractory. All of these patients had progressed on prior CDK4/6 inhibitor, but those really that are no longer kind of operating through an endocrine pathway. So if you feel that your patient really is not endocrine responsive, again, those that didn't get much benefit out of CDK4/6, those are the patients that may not really benefit so much from elacestrant. And you've already seen this as well, specifically looking at duration of therapy with CDK4/6 prior to elacestrant, that 12-month and beyond of benefit from CDK4/6, those are the patients that are going to benefit most from elacestrant. You've seen this as well, so in the interest of time, we'll skip over. So perhaps when the patient has progressed on CDK4/6 or prior endocrine therapies, this is no longer really an estrogen-mediated issue. There are other pathways at play that could be mediating that resistance. And one of those pathways is the PI3 kinase pathway. And so we've got a number of different medications that are approved or being investigated in the PI3 kinase pathway, both in AKT, which we'll talk about a little bit, in PI3 kinase, and mTOR with everolimus, which we've had around for a long time now. And so the SOLAR-1 trial was a phase 3 trial that we're all very familiar with now that investigated alpelisib plus fulvestrant versus fulvestrant plus placebo. And certainly there is a significant benefit from alpelisib in the PIK3CA mutated cohort, which is about 40% of patients with metastatic hormone receptor positive HER2 negative breast cancer. And that benefit was about 5.6 months in PFS, 11 months median PFS in the alpelisib arm, and 5.7 months median PFS in the placebo arm. But we've all seen this is a challenging drug to use. We're all kind of figuring out how to deal with the hyperglycemia and partnering with our endocrinology colleagues to see how we can mitigate some of this. And I would say as we're thinking about an algorithm for how we're dealing with these patients, knowing ahead of time that they have a PIK3CA mutation, so doing maybe your NGS on your initial tumor biopsy so that during CDK4/6 they have a PIK3CA mutation, and ultimately I'm probably going to want to use alpelisib. That's a great time to go ahead and refer them to endocrinology if they've got a pre-diabetic or mildly diabetic A1C. Start working on that A1C while they're on CDK4/6 so that by the time you're needing to use alpelisib, they already have a partnership with endocrinology, they've already had diabetes education, and maybe this can be still an option. In the SOLAR-1 trial, only 6% of patients had prior CDK4/6, which really doesn't represent how we use this in the clinic right now. So the BYLieve trial was really important that still showed benefit after CDK4/6. So again, looking at alpelisib kind of in this second or third line setting for patients who have the PIK3CA mutation. Kind of the new kid on the block now is inhibiting AKT, which overall is part of the same pathway. The AKT pathway includes PIK3CA, AKT, and PTEN, and this signaling also can cause resistance to endocrine therapy. So capivasertib is a potent selective inhibitor of all three AKT isoforms, was first looked at in the phase 2 FACTION trial, where they found that patients who had an alteration in one of these pathways tended to derive the most benefit. But then we saw at San Antonio this past year the Capitello trial, which is the phase 3 trial, placebo-controlled, looking at capivasertib plus fulvestrant versus placebo plus fulvestrant. And this included all patients, but they did look into whether or not they had these AKT pathway alterations. And they actually found benefit both in the intent to treat population and in the pathway altered population. This drug seems like it's a bit easier to use than alpelisib. The hyperglycemia grade 3 and above rate was 2.3%, so much better than what we're seeing with alpelisib, and similar diarrhea and rash as what we've been seeing with alpelisib. So I think ultimately we likely will be seeing an approval for this agent. The big question is, will the approval come in the intent to treat population, or will it come in the AKT pathway altered population? So does this trial belong in this talk? Not sure yet. But in addition, would this agent still work after they had alpelisib? I don't think this trial answers that question, and that will remain a question for us when the approval comes, if it's in the pathway altered population. So to think about, after CDK4/6, okay, put this all together, what should we actually do for these patients? Like Dr. Schwartzberg told you this morning, even if you've done NGS on your initial tissue for your metastatic biopsy to find out did they have a PIK3CA mutation, still a liquid biopsy at this time point is really helpful to detect those ESR1 mutations that you may not have found, particularly if they had, de novo disease. At the time of diagnosis of metastatic disease, you may pick them up now. So even if you've already done NGS, I would repeat a liquid biopsy now to look for your ESR1 mutations. And if they had more than 12 months on CDK4/6, elacestrant would certainly be my go-to in the second line. Also, it's so much easier to use than alpelisib. If they have a PIK3CA mutation, then alpelisib and fulvestrant would be my next option. Some patients will have both. These are not mutually exclusive mutations. Something like 10% of patients can have both PIK3CA and ESR1 mutations, and that would be where if they got less than, say 6 months on CDK4/6, I'd really be going for alpelisib, but if they had a longer duration, would be going for elacestrant. Capivasertib will become an option in future. Not exactly sure when that approval is coming. If they have no mutations, as we all know, everolimus and endocrine therapy is an option. If the progression is only mild, maybe is where the data from the MAINTAIN trial that we heard about this morning comes into play about switching endocrine therapy and using ribociclib, but again, would be cautious if they had already received ribociclib or abemaciclib, because the majority of the patients in that trial had palbo. Always want to keep in mind doing genetic testing in these patients to see if PARP inhibitor is an option. So that's what we'll talk about next. And this is in basically any patients with HER2-negative breast cancer. There are 2 different trials that we're going to talk about, which overall are pretty similar, the Olympiad trial and the Embraca trial. And they looked at patients with HER2-negative advanced breast cancer with germline BRCA mutations, and they were randomized to olaparib versus chemotherapy of physician's choice. And the end of the story basically is that there is a progression-free survival benefit. There's not an overall survival benefit. So while this is an important tool in the armamentarium for these patients, there is no survival benefit here. And we don't know exactly how to use this, say, in the patients who already received it now in the adjuvant setting, which we're not talking about here because we're talking about advanced breast cancer. But if they already had it in the advanced setting, unclear whether or not they'd have this efficacy in the advanced setting. And really, the story is very similar for Embraca, looking at talazoparib. They were randomized to talazoparib versus chemotherapy of physician's choice. PFS benefit, no OS benefit. You kind of see at the end of the OS curves, it kind of looks like there's some separation at the end, but there was no statistical significance for overall survival, and we've already seen a final overall survival analysis, so we're not going to get any more data from that trial. So on the basis of these trials, both olaparib and talazoparib are approved in advanced breast cancer with germline BRCA mutations, and they both have a PFS benefit without an OS benefit. There's not really a reason to choose one over another. They're both pretty similar. So again, in keeping with HER2 negative breast cancers. When we say HER2 negative, we mean they're not HER2 amplified, but you can actually still find HER2 mutations or ERB2 mutations in these patients. And so there was an interesting trial that we've had a couple of different readouts from called the SUMMIT trial. And it looked at patients who had these HER2 mutations but were not HER2 overexpressing. And they had both a hormone receptor HER2 negative cohort as well as a triple negative cohort. And really this involved looking at neratinib in these patients. And the combination that seems to have the most efficacy here is in the hormone receptor positive, neratinib, fulvestrant, and trastuzumab. And they had an overall response rate of about 38%, and they still had responses even if they had received some of, just fulvestrant alone or fulvestrant plus trastuzumab, had progression of disease and then received the 3-drug combination. There was still benefit there. And amongst the triple negative cohort doing neratinib plus trastuzumab, I think it's a nice additional option to have that's kind of different from what we've maybe already done for these patients. So something to keep in mind. And then you're all very well aware at this point of some of the tumor agnostic targeted agents. So for the interest of time, I've kind of just summarized them here. For MSI high, that there is a tumor agnostic approval for pembrolizumab. The frequency in metastatic breast cancer is something like 0 to 1.5%. I've not personally had a patient with MSI high breast cancer. The overall response rate, which was taken from the trial that looked at many different solid tumors, was 30%, and about 4% of the patients on that trial had breast cancer. So we don't really have specific data just for breast with MSI high. High TMB, we also have a tumor agnostic approval for pembrolizumab, and that's generally considered to be 10 or more mutations per megabase, which we do see actually in metastatic breast cancer on the order of around 10%, with overall response rates that are in kind of the 20 to 30% range. But interestingly for these patients, even though the overall response rate is not overwhelming, there are going to be some patients who have prolonged benefit. So I certainly think if you've already exhausted a lot of different options, this can be an interesting option. One note about TMB is that if you are testing this in a liquid biopsy tends to overestimate TMB, which is kind of interesting because per the FDA approval, the companion diagnostic is Guardant. But the liquid biopsy tends to overestimate TMB on the order of like 1.5 to 2 times. So if I'm really looking at a menu of options for a patient and trying to talk to them about what option I think is going to work best for them, if I'm using liquid biopsy, I'm using more of a cutoff of like 20 for TMB, and then 10 if it's in a tissue-based testing. Certainly if you're scraping the bottom of the barrel and you're just looking to get something approved, you'll get it approved on 10 TMB with a liquid biopsy, but wouldn't necessarily expect a great response with that. And then NTRK fusions and RET fusions, they are reported in breast cancer, but we certainly don't see them very often, and they have their approved options here. So just a couple of points on using ctDNA in breast cancer. If any of you went to San Antonio last year, you saw an incredible number of posters and presentations regarding circulating tumor DNA, and I think this is something that really is coming to the forefront all over oncology, and breast cancer is no different. You're all well aware this is a type of cell-free DNA that comes from apoptosis of tumors, from circulating tumor cells. And there are a number of different assays for measuring ctDNA. I think the important thing here is using the right test for what you are trying to achieve. The cancer panel testing is what we're all used to seeing with like a Guardant liquid biopsy. It's kind of a nice balance of sensitivity and being able to look at a number of different genes, whereas PCR has excellent sensitivity to look for one gene. And whole exome sequencing looks at a large array of genes, but low sensitivity. And some of the challenges in interpretation of your liquid biopsies are clonal hematopoiesis of indeterminate potential, which you can pick up on liquid biopsies, and you know if you're seeing some of these mutations that kind of make you think of the flavor of MDS-AML, that likely, in a patient without those conditions, represents CHIP. And then another challenge is the false negative rate with ctDNA, particularly in breast cancer. If you're thinking of someone, say, with bone-only disease, it's very common that you won't necessarily pick up ctDNA, or if they're in a time of good disease control. So really the best time to use ctDNA in breast cancer is when they're progressing. And then certain types of tumors are going to just shed less ctDNA, such as your ER-positive, HER2-negative, as opposed to HER2-positive and triple-negative. For the interest of time, I'm going to skip over the PATA trial, but just kind of highlights interesting applications of ctDNA in clinical research. Here is a summary of the biomarkers in metastatic breast cancer that have approved targeted therapies. One thing I didn't mention here is the androgen receptor, which does not yet have an approved therapy in metastatic breast cancer, although I have gotten enzalutamide approved for androgen receptor positive metastatic breast cancer in the past. There are clinical trials coming in that space that will give us more kind of anti-androgens for androgen receptor positive metastatic breast cancer. And in conclusion, important for NGS panel-based testing to be done on all patients with metastatic breast cancer, particularly those that are ER positive and HER2 negative, and really the best time point to do that is after progression on CDK4/6 when you're looking to determine a second-line treatment, and that genetic testing should also be offered to all patients with advanced breast cancer. Thank you.